So this is a case of 60 years diabetic male admitted with history of acute AG with sepsis. On day 3 of admission, he is complaining of respiratory distress, right pleuritic chest pain and developed hypoxia. So the chest X-ray demonstrated presence of right middle lobe pneumonia. So actually middle lobe consolidation, right middle lobe consolidation. His initial chest X-ray was normal. So what is the diagnosis? Why this is a case of hospital acquired pneumonia? Yes, after 48 days of admission in hospital, the patient developed pneumonia. So this is a case of hospital acquired pneumonia, right? Next is 25 years female admitted with a history of ingestion of kerosene one day back. Since then complaining of dry cough with left sided chest pain, but surprisingly she is not having any hypoxia or any signs of fever, right? So what could be the diagnosis? Is it community acquired pneumonia, is it aspiration pneumonia, or is it chemical pneumonitis? Or no, this is a case of chemical pneumonitis, right? Because why this is not a aspiration pneumonia? So I mean next in my next slide there is a MCQ regarding aspiration pneumonia. Then I will discuss this, why this is this is not a case of aspiration pneumonia, but why this is chemical pneumonitis, because she ingested kerosene. So actually some irritant chemicals like kerosene, diesel, they causes inflammation of the parenchyma, lung parenchyma, not infection. So this is a case of chemical pneumonitis. So this is another one MCQ, 70 years old patient, bedridden, semi-conscious, admitted with history of cough with mucopurulent expectoration and low grade fever for last 7 days. So this is the chest X-ray of the patient, right? So can you appreciate what is the finding of the chest X-ray? So there is inhomogeneous opacity in right lower zone. What is the diagnosis? Is it community acquired pneumonia? Is it hospital acquired? Is it aspiration pneumonia or none? So this is a case of aspiration pneumonia. Why this is a case of aspiration pneumonia? So there are some clues in the question itself. Prolonged bedridden, semi-conscious patient. So what is the mechanism of aspiration pneumonia? Anyone? Actually, all of us every day microaspirates every second, right? But we are not developing any aspiration pneumonia. So what happens in certain cases, certain conditions, like certain patients like alcoholic patients or patients with poor dental hygiene, they harbors more pathogenic anaerobic organism that may cause pneumonia. Microaspiration. So actually first of all the pathogenic organism is different from us, first. Second, the quantity of the pathogenic organism is more than that of a normal human being. So that aspiration actually produces significant amount of infection, first. Second, in those patients with depressed cough reflex, depressed swallowing reflex, so they cannot cough out their expectoration, and in those cases, in patients of cerebrovascular accident, CVA patients, or in case of Parkinson's patient, neurologically depressed patient, in those cases, what happens? They aspirate and they cannot cough them out, and accidentally, so their caregiver may try to give them food, but they cannot swallow because their swallowing reflex is also impaired because of the neurological problem. So that food particle actually directly enters to the lung through the trachea, respiratory system. That may cause also pneumonia. This is called, so these are the causes of aspiration pneumonia. So what are the sites of aspiration? There are two typical sites of aspiration pneumonia, because when we lie down, our most dependent portion of the lung are right upper lobe posterior segment and anterior segment of the right lower lobe. these two are the most dependent position when we lie down. This is anatomical position, right? So aspiration, those aspirated contents easily that comes through these two segments, right upper lobe posterior segment and right lower lobe anterior segment. Also, the structure of the bronchus in right lower lobe is not as straight as the left lower lobe. So the secretions cannot easily come out, right? So this is why these are the typical sites of aspiration pneumonia. So when this type of patients, semi-conscious patients, alcoholic patients, or with poor oral hygiene patients come with this kind of symptoms, cough with low grade fever, then there is no high grade fever, because they are not typical pathogen, they are anaerobic pathogens. So the pneumonia produced by them causes mild rise of temperature, not high grade of fever or chills or rigor, that is present in typical pneumonia. So this is case of aspiration pneumonia. So the stage of grey hepatization, which day? So yes, 4 to 6 days, 2 to 3 days is red hepatization and more than 7 days resolution. Hyponatremia is associated with which type of pneumonia? Staph, Mycoplasma, Legionella or Leptospira? Which type of pneumonia causes hyponatremia? Actually SIAD. Which type of pneumonia? Is it Staph aureus? What are the cardinal features of Staph aureus pneumonia? Anyone? আগের দিন সব বলেছি. What are the cardinal features of Staph aureus pneumonia? High grade fever, that the symptoms are more than that of sign. High grade fever, sepsis, septic shock with a history of IV drug abuser or this immunocompromised status. Mycoplasma, Legionella, Leptospira, these all three are the atypical pathogens. So they produces influenza-like illness. That means coryza, cough and influenza-like other illnesses. So they are not typically presenting with high-grade chills and rigors with fever, high-grade fever. So Mycoplasma, what are the extrapulmonary manifestation of Mycoplasma pneumonia? Name any one or two. You have to go through all the lectures every day, daily, right? Because medicine syllabus is itself very huge. You cannot cover it up within 1 year. তাহলে তোরা যদি না কালচার করিস সেগুলো তাহলে তো মুশকিল হয়ে যাবে, পরে তো কোপ আপ করতে পারবি না। So extrapulmonary manifestations of Mycoplasma, most common bullous myringitis, right, and erythema nodosum and other neurological problem, any GB syndrome. Okay, so Legionella actually causes hyponatremia, diarrhea with hyponatremia, and in case of Leptospira it is icterohemorrhagic fever, jaundice with hemoptysis with pneumonia. This triad is called icterohemorrhagic fever or Wells syndrome, Wells disease or Leptospira. Okay, so high grade fever, cough with purulent expectoration, BP is low, SpO2 is low, IV drug abuser and suffering from infective endocarditis. And this is the picture of his chest X-ray. What may be the diagnosis? I will not give any clue or any options. I have just mentioned the name. No. Which organism? Staph aureus, because this is a case of bronchopneumonia, right? Bilateral, not confined to any specific lobe or segment, and patient presents with high grade fever with mucopurulent expectoration, having septic shock and hypoxia itself, right? And IV drug abuser with infective endocarditis. So these all are the clues favoring for the Staph aureus pneumonia. Okay. Next, 50 years old diabetic male with cystic fibrosis, admitted with fever with left sided chest pain and mucopurulent expectoration. That means the patient is immunocompromised and having structural lung disease, cystic fibrosis, right? So what is cystic fibrosis? Any idea? Any idea? Pathology হয়েছে পড়েছিস? Cystic fibrosis is a genetical disorder, right? So what happens in case of cystic fibrosis? There is CFTR gene mutation. Cystic fibrosis gene name is CFTR gene mutation, which regulates ENaC channel, which actually ENaC channel কোথায় থাকে? Presence in alveolar epithelium, right? So সেখানে কি হয়? ENaC channel regulates the concentration of the mucus production. Sodium and chloride channel mucus production concentration depend করে. But when there is a mutation of ENaC channel, there is disproportionate sodium and chloride content in mucus. So the mucus become very thick. The patient cannot expectorate the mucus. So the mucus accumulates inside the bronchus, results in infection, recurrent infection. So this is the pathophysiology of cystic fibrosis. So cystic fibrosis definitely is a structural lung disease, right? And immunocompromised. So you can appreciate there is left upper zone inhomogeneous opacity, so left upper lobe pneumonia, and this is the culture plate picture. Most probable diagnosis, yes, Pseudomonas. So in cystic fibrosis patients, most commonly Pseudomonas, Klebsiella and Staph aureus. These three organisms are abundant in nature. Okay, fine. So next today's lecture about investigation and of pneumonia, right? So before we proceed to investigation, we have to clinically examine the patient very well, right? So in history taking, what history may the patient give to you? What kind of history? History taking নিয়েছিস মানে কিভাবে নিতে হয়, কোনো আইডিয়া? চিফ কমপ্লেন, হিস্ট্রি অফ প্রেজেন্ট ইলনেস। সো হিস্ট্রি অফ প্রেজেন্ট ইলনেসে পেশেন্টের নিউমোনিয়া পেশেন্টের কি কি তোর কাছে প্রেজেন্ট করবে? First, cough. Okay, the nature of cough may be dry, mostly mucopurulent in nature, right, with profuse expectoration. May or may not be associated with hemoptysis, right? Next, fever. Fever may be of high grade, may be of with chill and rigor, and may not be with associated with high grade fever. So in which pneumonia there may be low grade fever? Which kind of pneumonia? All the pneumonia causes by atypical pathogens and anaerobic organisms. Either kintu fever will be low grade, right? And will be not associated with chill or rigor, right? So next, chest pain. Chest pain, which kind of chest pain? Sharp stabbing chest pain that increases with cough and deep inspiration, pleuritic chest pain. Okay, next, other histories, other type of histories, shortness of breath. Okay, so what may be the findings of general examination? Palocyanosis, clubbing, jaundice. Any clue? For pallor. Pallor may be or may not be present. Pallor is a non-specific, actually non-specific signs of inflammation. Chronic inflammation may cause anemia, right? Anemia of chronic disease. In patients of tuberculosis, the patient may present with severe pallor because of anemia of chronic disease. But pallor with hemoptysis, with pneumonia, with jaundice, so this is a triad of leptospira. তো বললাম একটুনি ictedohemorrhagic fever, right? Leptospira. Okay, next cyanosis. Cyanosis may be present in severe pneumonia, in severe hypoxic state. Clubbing, generally clubbing is absent in case of pneumonia, but when pneumonia is complicated with other diagnoses like lung abscess or empyema, then clubbing may be present. Next, neck gland palpable or not. In which pneumonia lymph node lymphadenopathy may be seen? Which type of pneumonia or which kind of pneumonia? Tuberculosis. In tuberculosis, there may be presence of enlarged lymph nodes, right? Yes, patient may be tachypneic, may be tachycardic, or may be in septic shock. That means his systolic blood pressure may be less than 90 or diastolic blood pressure may be less than 60 millimeter of mercury. But in case of this tachypnea, tachycardia and septic shock, in case of severe community acquired pneumonia. And very importantly, higher function, conscious or not. Why this is important? Why consciousness level assessment is very important in pneumonia? First, cause of pneumonia, aspiration pneumonia or not. Second, severity of pneumonia. There is a score called CURB 65 score, CURB 65. আমি পরে আসবো এখানে। So the first point of CURB 65 score is consciousness, right? If the patient is not conscious, then you may treat it as severe pneumonia. Okay, fine. So next, respiratory system examinations. Inspection. What are the points of respiratory system examination? Inspection, palpation, percussion and auscultation, right? So inspection, কি inspection এ finding আসতে পারে একটা pneumonia patient এর? Respiration এ tachypnea থাকবে, intercostal indrawing থাকবে and accessory muscles এর working, ঠিক আছে? তারপর আর কি থাকতে পারে? Any change of shape or movement in pneumonia patients? Yes, if pneumonia is complicated with pneumothorax or pleural effusion, then shape, the unilateral bulging of the chest wall or decreased unilateral movement of the chest wall along with pneumonia raise a strong suspicion in favor of pneumothorax or pleural effusion. Okay. So palpation, there may be localized, yes, trachea first, no? Localized temperature and tenderness is the first point of palpation. So localized temperature may be elevated in certain cases of pneumonia. In which cases? If pneumonia is complicated with pleural effusion, parapneumonic effusion or empyema, if there is pus in pleural cavity, this is called empyema. So if pneumonia is complicated with pus in pleural cavity, so then the patient may have raised local temperature in chest wall. Okay, tenderness may be or may not be present. Fine. So next, palpation, other points, movement may be restricted or may not be restricted. Okay, expansion may be restricted in severe case of pneumonia. If patient is hypoxic, patient is having severe chest pain, then the chest expansion will be restricted, right? Next, vocal fremitus. What is vocal fremitus? কি করে দেখে জানিস vocal fremitus? Yes, right. So vocal fremitus will be increased or decreased in pneumonia. increased, right, increased, because there is a consolidation. So that ওই যেগুলো nasal intonation হয় 3 3 3 3 3 3 9 9 9 এগুলো এই সাউন্ড গুলো ওখান দিয়ে আরো বেশি ইন্টেন্স হবে, রাইট? So percussion, dull note or percussion on consolidated area, right? And auscultation, auscultation এ কি পাওয়া যাবে? There will be vesicular breath sound all over, but the area, in the area of involvement, pneumonia involvement, that particular area, in that particular area there will be bronchial breath sound. Okay, most commonly tubular type of bronchial breath sound, right? So what is the difference between vesicular and bronchial breath sound? যখন প্র্যাকটিক্যাল হবে আমিই পড়াবো তখন দেখিয়ে দেবো কিভাবে এই ডিফারেন্সিয়েট করতে হয়। এনি আইডিয়া? High pitch. Next, there is a gap between inspiration and expiration, and inspiration and expiration will be same, duration will be same, and there is high pitch, right? So bronchial breath sound. Next, crepitation will be heard on the area of involvement. So actually there are two types of crepitation, indux crepitus and redux crepitus. That means during the induction of pneumonia, during the first phases of pneumonia, there is fine crepitations, and during the reduction of the pneumonia, there is another reappearance of the crepitation. So this is called indux and redux crepitus. Okay, pleural rub may be present if there is significant pleural inflammation, right? Next one is VR, vocal resonance will be also increased, right? This is bronchial breath sound. সাউন্ডটা বাড়াতে, সাউন্ডটা বাড়াতে, অ্যাপ্রিসিয়েট কর। কি মনে হচ্ছে একটা টিউব এর মধ্যে দিয়ে একটা যাচ্ছে, রাইট? ব্লো করছে কেউ একটা। বেসিক্যালি তুই bronchial breath sound is easier যদি তুই তোর স্টেথো তো ট্র্যাকিয়াতে রাখিস, রাইট? সো দিস ইজ এ হলো টিউব। সো ট্র্যাকিয়াতে রাখলে যে সাউন্ড আছে দিস ইজ bronchial breath sound, টিউবুলার bronchial breath sound। ঠিক সিমিলারলি এখানেও পাওয়া যাবে টিউবুলার bronchial breath sound। This is the sound of crepitation. দেখছিস? Okay, fine. Then next, radiological investigation. First, chest X-ray. So ঠিক আছে, এগুলো নর্মাল, এগুলো কিছু চেস্ট এক্সরের এক্সাম্পল আছে, বাট এগুলো আমি এক্সরে ক্লাসে আলাদা করে পড়াবো। এগুলো সো অ্যাকচুয়ালি আমি এইগুলো এটা পরে আমি পড়াবো, হোয়াট ইজ পালমোনারি এডিমা, হোয়াট ইজ কার্ডিওমেগালি, আমি পরে আমি এক্সরে ক্লাসে পড়িয়ে দেবো। সো দিস ইজ inhomogeneous opacity involving right lower zone. So this is right lower lobe pneumonia. Types of pneumonia can be identified by chest X-ray. This one, this is lobar pneumonia, right upper lobe. This is fissure. This is also lobar pneumonia, and this is there is a cavity, right? Cavitary pneumonia, and this one is also lobar pneumonia, but this is an interesting sign. The fissure bulges out, right? This is the horizontal fissure. Horizontal fissure এইটা, এই যে এরকম horizontal, but the fissure bulges downward. This is called bulging fissure sign, typical of Klebsiella pneumonia, right? Because Klebsiella pneumonia most commonly involves right upper lobe. So Klebsiella pneumonia produces so much exudates that it's the parenchyma and the exudates itself actually pressurizes the consolidated area, and the exudates actually pressurizes the horizontal fissure and make it bulges downward. So because of the weightage of the exudate. The fissure bulges downward. This is called bulging fissure sign. Fine. So this is a case of bronchopneumonia, right? And this is also a case of cavitary pneumonia. This is a cavity. Okay. Yes, resolution can also be assessed by doing a chest X-ray, but radiologically resolution of pneumonia, complete resolution within 6 weeks and partial resolution within 4 weeks, right? So this is initial chest X-ray. This is a case of right-sided bronchopneumonia, and after giving therapy after 3 weeks, this is the X-ray. There is partial resolution, not complete resolution. Next, microbiological investigations. তুই basically investigate করলি, X-ray করলি, তারপরে তুই পেলি যে pneumonia. Yes, this is a case of pneumonia. So, what are the most important and primary microbiological investigations? Because তোকে তো isolate করতে হবে what is the main causative organism, right? So, main microbiological investigation is sputum test. Sputum, gram stain and culture sensitivity. But most importantly, not to collect saliva. Always collect sputum, maybe mucoid or maybe mucopurulent, right? So, কিভাবে তুই বুঝবি যে কোন রিপোর্টে this is a case, this is saliva or this is sputum? কিভাবে বুঝবি? So, there are two basically indicators. One is number of epithelial cell and number of pus cell. If epithelial cell number is less than 10 and pus cell number is more than 25 per power field, then it is purulent sputum, right? Infected sputum. Okay, so যখনই তুই দেখবি এই স্পুটামটা আসছে less than 10 buccal cell or epithelial cell with more than 25 neutrophil, তখন এটাকে কালচারে পাঠাবি। সো মানে এখান থেকে there may be high yield of giving positive culture result. Send for gram stain culture, AFB, D1, D2, Zn stain and fungal stain. Fungal stain সবার দরকার নেই, AFB stain সবার দরকার নেই, Zn stain সবার দরকার নেই। কাদের দরকার আছে Zn stain সেটা আমি যখন টিভি পড়াবো তাদের বলবো। But always send sputum for gram stain culture sensitivity. Fungal stain কাদের দরকার? Fungal stain হচ্ছে basically in severely immunocompromised individual, pneumonia হচ্ছে, হ্যাঁ, এই পেশেন্টদের হচ্ছে ফাঙ্গাল স্টেন দরকার, ঠিক আছে। ভেরি ইম্পর্টেন্টলি, যারা স্পুটাম বেসিক্যালি দ্য পেশেন্ট প্রেজেন্টস উইথ ড্রাই কাফ, দে ক্যান নট এক্সপেক্ট টু এ প্রপার স্পুটাম, দেন স্পুটাম মে বি ইনডিউসড। দিস ইজ কল্ড ইন্ডাকশন অফ স্পুটাম বাই গিভিং হাইপারটনিক স্যালাইন। কি করছিস তুই? বাই গিভিং hypertonic saline, mucus production will increases, right? Bronchospasm followed by mucus production, more mucus production. So this is induced sputum, right? Hypertonic saline or maybe collected by bronchoscopy itself. Bronchoscopy first দিন একটা দেখিয়েছিলাম ভিডিও, অ্যানাটমিক্যালি ওইভাবে bronchoscopy করা হয়। So in case of pneumonia, specifically severe pneumonia with septic shock and high grade fever with septic shock and hypoxia, always collect blood culture along with sputum culture. But সবসময় মনে রাখবে একটা কথা, before giving the first dose of antibiotic, all culture should be sent. যদি ফার্স্ট ডোজ অফ অ্যান্টিবায়োটিকের পরে হয় তাহলে কিন্তু কালচারে কিছু না আসার চান্স বেশি। So the sensitivity of sputum culture of pneumococcus is only 50%, not 80%, more than 80%, but only 50%. এখানেও false positive, false negative আসার চান্স অনেক বেশি। Yes, the main problem is to isolate the commensal flora, যেটা আমি এতক্ষণ বলছিলাম। আমাদের সবারই তো commensal flora আছে, they are non-pathogenic. So how to isolate between the commensal flora or the there is the pathogenic flora, because if the colony count is more than 10 to the power 5 CFU per ml, then this is pathological. Other additive test you can do apart from the sputum, but this is the mainstay, sputum and blood culture. Apart from that is urinary antigen in certain pneumonia, in case of Legionella and pneumococcus pneumonia. Urinary antigen may be helpful, but this is the specificity is not as good as sputum. Sputum immunodetection, there is direct immunofluorescent antibody test in atypical pathogens like chlamydia and Legionella. It may be helpful. And so that's why these organisms are called atypical, because they cannot be cultured, right, in proper way. So sputum e তুই Legionella mycoplasma পাবি না, কালচার করা যায় না। So তাদের ডায়াগনোসিস এর ওয়ে হচ্ছে this one, DFAT. And DNA PCR is for viral pathogens, right? And also PCR may be helpful in detecting tuberculosis also, Mycobacterium TB. That is called CBNAT, cartridge bed nucleic acid amplification test. Serology in specific case, like in case of Klebsiella bandeti pneumonia, 4-fold rise of IgM value, but very difficult to interpret definitely. And blood investigations, কোন blood investigation send করবি, কি জেনারেল আইডিয়া, কোন ইনফেকশন হলে আমরা কি ব্লাড পাঠাই? সিবিসি। সো সিবিসি তে কি ইন্টারপ্রিট করবি? WBC count, yes. If it's more than 12,000 or less than 4,000, right? And most importantly, NLR or NL ratio, neutrophil lymphocyte ratio. If more than 3.1, right? This, so এইগুলো ইন্ডিকেট করে সিভিয়ার নিউমোনিয়া, নিউট্রোফিলিয়া, রাইট? আচ্ছা, নেক্সট টোটাল WBC কাউন্টের পর CRP, yes, CRP is a marker, but CRP is non-specific marker of infection. CRP করে you cannot identify whether this is a case of bacterial pneumonia or this is a case of viral or this is a case of fungal pneumonia, right? Because this is a sign of inflammation or infection itself, but not pathological, you cannot pathologically correlate, right? So CRP is non-specific, but specific one is procalcitonin. Procalcitonin, this is a marker of bacterial or infection. So in any kind of bacterial infection, be it pneumonia, be it urinary tract infection or any other kind of infection, if you differentiate between bacterial organism or viral organism, then procalcitonin is a good marker, right? ESR is also non-specific. ESR তো আরো non-specific, CRP থেকেও non-specific. যে কোনো ইনফেকশন হওয়ার দরকার নেই, ইনফ্লামেশন হলে ESR বাড়তে পারে, ইভেন অ্যানিমিয়াতে ইটসেলফ ESR বাড়ে। Next is renal function test. So increased burn, right? এই যে এটা কেন, because it indicates severity, আমি বললাম না CURB স্কোর, তার মধ্যে একটা কম্পোনেন্ট ইজ বার্ন, ইউরিয়া, U for urea, right? Definitely electrolytes, hyponatremia, কোন নিউমোনিয়া? Legionella, right? Okay. ABG, arterial blood gas, যেটাতে কি ডিটেক্ট করবে? টাইপ 1 respiratory failure, that means hypoxia, right? Yes, next assessment of severity. So এটা ভীষণ ইম্পর্টেন্ট, because this is called ATS, American Thoracic Society Severity Classification of community acquired pneumonia. So if any one of the two major criteria. First one is hypoxia, severe hypoxia that needs mechanical ventilation, and second one is hypotension or shock that needs vasopressor support, not adrenaline support. So any one of the two if present, then this is a case of severe community acquired pneumonia, right? And other minor criteria, so other minor criteria like if the patient is tachypneic, if there is bronchopneumonia, multilobar infiltrates, or WBC count is less than 4,000, or the patient is confused, or his burn creatine ratio is high, right? So, and the patient is hypothermic, patient is thrombocytopenic. So, any three of the minor criteria if present, then it is severe cap. This is CORB 65 score. তোদের এইটা মনে রাখতে হবে, জাস্ট এই তোরা মনে রাখবি এই মেজর দুটো ক্রাইটেরিয়া, তাহলেই হবে। দিস ইজ ইম্পর্টেন্ট। মেজরের একটা থাকলে এটা সিভিয়ার, রাইট? বাট এটা হচ্ছে CORB 65 স্কোর হচ্ছে তোর ফার্স্ট সি ফর কনফিউশন, যেটা আমি বলেছিলাম সি। সেকেন্ড ইউ ফর ইউরিয়া মোর দ্যান 7 millimole per liter, R for respiratory rate if patient is tachypneic, that means RR is more than is equals to 30 per minute. BP, SBP is less than 90 or DBP is less than 60, and 65 means age is 65. এখন যেটা আমরা ইউজ করি, বিকজ দিস ইজ এ অ্যাকচুয়ালি এটা কি সিভিয়ারিটি অ্যাসেসমেন্ট স্কোর, তাই তো, মর্টালিটি অ্যাসেসমেন্ট স্কোর, রাইট? এটা থেকে কি করতে হবে, মানে কি ইন্টারপ্রিট করব, CORB 65 স্কোর করে আমি কি করব? সো I have to decide where to treat the patient. If the patient, I can treat the patient in OPD or in ward or in ICU, right? So this is the score, CORB 65. So if the score is more than 3, definitely you should send him to ICU, right? If it's less than 1, 0 to 1, 0 to less than 1, then you should treat it in only OPD, right? বাট এটা তো বেডসাইড, আমরা তো বেসিক্যালি বেডসাইড করতে হবে। তোর কাছে একটা পেশেন্ট এলো, রাইট? তোর কাছে পেশেন্ট এসছে, তুই পেশেন্টকে দেখেই সঙ্গে সঙ্গে বলবি না তুমি আইসিইউতে যাও, না তুমি এখানে যাও। বাট তুই কি এটা করতে পারবি? বিকজ এখন করতে পারবি না, বিকজ দের ইজ ইউরিয়া। তোকে তো ইউরিয়া অ্যাসেসমেন্ট করতে হবে, ব্লাড ড্র করতে হবে, আবার পাঠাতে হবে, তার রিপোর্ট আসবে, তাই অ্যাসেস করবি। সো দিস ইজ নট এ বেডসাইড টুল। টু মেক ইট বেডসাইড, the committee has decided কি করেছে না ইউটাকে উঠিয়ে দিচ্ছে, CRB 65। এখন নতুন যে ক্রাইটেরিয়া, দ্যাট ইজ CRB 65। সো মোর দ্যান 2, এখানে মোর দ্যান 2 হচ্ছে তোর এতে, বিকজ একটা পয়েন্ট উঠে গেছে, আর লেস দ্যান 1, ঠিক আছে? দিস ইজ এ ভেরি কমপ্লেক্স স্কোর, মনে রাখার দরকার নেই। দিস ইজ কল্ড PSI, নিউমোনিয়া সিভিরিটি ইন্ডেক্স স্কোর। দিস ইজ most well validated score. More than 20, that means severe infection. Okay, so sorry, more than 90, for the 90 score is severe pneumonia. Okay, next, complications of pneumonia. Kichu idea, any idea about complications of pneumonia? যে কোনো ইনফেকশন যদি হয় তার দুটো কমপ্লিকেশন যদি তোকে বলে, সাপোজ তোকে বললো যে হোয়াট আর দ্য কমপ্লিকেশনস অফ ইউরিনারি ট্র্যাক্ট ইনফেকশন, তো যে কোনো ইনফেকশন যদি হয় তার দুটো কমপ্লিকেশনস হয়, ওয়ান ইজ লোকাল অ্যান্ড ওয়ান ইজ সিস্টেমিক। যে কোনো ইনফেকশন, ঠিক আছে? তো বল সিস্টেমিক, আচ্ছা ফার্স্ট হচ্ছে লোকাল কমপ্লিকেশনস কি কি হতে পারে? if you will not treat adequately the pneumonia, or pneumonia itself is drug resistant pneumonia, যে অর্গানিজমের জন্য তুই মানে যে অ্যান্টিবায়োটিক দিচ্ছিস দ্যাট ইজ রেজিস্ট্যান্ট টু দ্যাট অর্গানিজম, ঠিক আছে? সেটা হতে পারে। তখন কি হবে, তখন লং টার্ম একটা কমপ্লিকেশনস হবে, লোকাল কমপ্লিকেশনস। কি হতে পারে? লোকাল মিন্স লাং কমপ্লিকেশনস। কি লাং কমপ্লিকেশনস হতে পারে? মেবি প্লুরাল এফিউশন, এমপাইমা, পাস ইন প্লুরাল ক্যাভিটি, লাং অ্যাবসেস, ঠিক আছে? ইভেন নিউমোথোরাক্স অলসো। ইন কেস অফ ক্যাভিটারি নিউমোনিয়া, সাপোজ ক্যাভিটি মানে হোয়াট ইজ ক্যাভিটি? বেসিক্যালি দেয়ার আর সার্টেন organisms লাইক Klebsiella, Pseudomonas, এরা কি করে নেক্রোটাইজিং নিউমোনিয়া করে, মানে প্যারেনকাইমাকে নেক্রোটাইজ করে, অ্যান্ড অ্যানারোবিক ইনফেকশনস অলসো। তো নেক্রোটাইজ করে কি করবে, সেই নেক্রোটাইজড প্যারেনকাইমাতে কি হবে না, সেখানে একটা ক্যাভিটি ফর্মেশন হয়ে যাবে, এয়ার হবে, এয়ার অ্যান্ড দ্য কনসোলিডেটেড এরিয়া উইথ পাস সব একসঙ্গে থাকবে, দিস ইজ কল্ড ক্যাভিটি। সো যখন ক্যাভিটি রাপচার করবে তখন এয়ারটা লিক আউট হবে, তাহলে নিউমোথোরাক্স হতে পারে, এমপাইমা হতে পারে, ইনফেকশন হতে পারে, রাইট? So this is empyema, pus in pleural cavity, right? Lung abscess, this is extra of lung abscess, air fluid level, horizontal air fluid level. And systemic complications কি কি হতে পারে? ঠিকই বলছিস, বল। সেপসিস, সেপটিক শক, আর কি হতে পারে? respiratory failure, আর multi organ dysfunction, infective endocarditis, specifically in staph pneumonia, ঠিক আছে?